In this lecture, we will discuss left posterior fascicular block, including its pathophysiology, EKG features, and clinical significance. If you recall, the normal electrical conduction system of the heart starts with the sinus node, or the SA node in the right atrium. So if you look here, we have our sinus node up in this upper right atrium, okay, our SA node, okay. Here's our superior vena cava, all right. Remember, this is our right atrium, this is our left atrium, right ventricle, and left ventricle. So we start with the sinus node, then we have these internodal pathways in the Bachmann bundle going to the left side, and then here we have our AV node, okay? Our AV node, that's in the lower portion of our right atrium. Then we have this His bundle, okay? The His bundle then gives off our right and left bundle branches, okay? The right bundle branch comes to the right ventricle and innervates that, and then we have our left bundle branch that then gives off and subdivides into a left anterior fascicle and the left posterior fascicle, okay? So we have those two fascicles, the left anterior and left posterior, as well as the right bundle branch, that then go to our Purkinje fibers, and then they innervate our myocardial cells, okay? So generally, we have a left anterior fascicle that's organized, and it's a thin bundle of fibers coming off the left bundle, and that gives rise to the Purkinje fibers, okay? That innervates the anterior and lateral walls of the left ventricle, okay? So our left anterior fascicle is the anterior and lateral wall of the left ventricle. It innervates. And then we have the left posterior fascicle that again originates from the left bundle branch. Its fibers are not organized into a tight fascicle, but rather they're dispersed and loosely fanned out. The left posterior fascicle innervates the inferior and posterior walls of the left ventricle. So here's the left posterior fascicle, we said, inferior and posterior walls, okay? So just remember those. So as you can see, the left bundle branch subdivides into these two main fascicles. We have the left anterior fascicle and the left posterior fascicle. And the term fascicular block or hemiblock refers to an anatomical or functional dysfunction in one of these fascicles. In other words, the conduction block of the left anterior fascicle is referred to as a left anterior fascicular block, sometimes referred to as a left anterior hemiblock, okay? And then we have a conduction block in the left posterior fascicle, which we call a left posterior fascicular block or left posterior hemiblock. Hopefully those make sense. Now, just a quick clinical note that we'll mention again later: because the left posterior fascicle is more dispersed and less organized than the left anterior fascicle, it's more resistant to ischemic injury. It also receives a greater arterial blood supply, which contributes to its protection. All right, so these fascicular blocks cause the ventricles to be innervated asynchronously and aberrantly. Therefore, the vectors produced by the left ventricle will be altered and will affect what we see on the EKG in each case. Our focus in this lecture is the left posterior fascicular block, okay? So let's just clear some of this up here as we move forward, okay? So we have our left posterior fascicular block that we're focusing on in this lecture, where we have this block occurring right in this region, okay? Notice that red mark that's showing that our block is occurring in our left posterior fascicle, okay? So left posterior fascicle, remember, it innervates the inferior and posterior portions of that left ventricle. Remember, we said that it's the inferior and posterior walls, okay, that are innervated by it, and because this fascicle is blocked, depolarization of the inferior and posterior walls of the left ventricle will now be delayed. This results in a stronger unopposed vector that we have going rightward and inferiorly, okay? So again, we have this left posterior block, okay, that innervates the inferior and posterior walls of the left ventricle. All right, so initially the left anterior fascicle is doing fine. So our anterior and superior and lateral portions of the heart will be innervated by this vector going that way. And then we'll have this vector that comes the other way, this slow cell-to-cell depolarization, this stronger vector that's going to come inferiorly and posteriorly, and that we call this vector number 2 in this point, okay? Now, because the vector is not in that normal inferior and leftward direction, but instead in the inferior and rightward direction, this is where we get right axis deviation, okay? The electrical axis is now in that right quadrant of the hexaxial system, or the frontal plane, specifically between positive 90 and positive 180 degrees. So again, notice our vector here, the second vector here, heading rightward to the right side of the heart, as well as inferiorly, okay? And because it's heading in that direction, we're going to get a shift in our axis. Normally it should be heading this way, okay, it's going to now be going more rightward. Here's our normal QRS axis or ventricular axis between -30 and +105, okay, or +110 degrees. And what we're saying here is now we have a shift into our right quadrant, okay, in this region here, anywhere between +90 and +180 is where we see our shift in our axis, because that second vector is now shifting things over here, okay? So a rightward axis shift is what we see in the frontal plane, and that's one of our first criteria. Now let's look at some of the other EKG features. We can see RS complexes in the lateral leads, 1 in AVL, whereas in the inferior leads, 2, 3, and AVF, we'll see these QR complexes, okay? And some suggest that we must see small Q waves in at least leads 3 and AVF. And notice that we're saying these RS complexes in the lateral leads and the QR complexes in the inferior leads are composed of small initial R and Q waves respectively. These small waves result from the unopposed interventricular depolarization vector. Okay, so let's just go over this now. I want to erase this so we can look at where our vectors are going and why we see what we see on the EKG. Okay, so again, we have lead 2 here, lead 3, and lead AVF. Okay, these are our inferior leads on the inferior portion of a heart. And then we have lead AVL up here, and then lead 1. Okay, our lateral leads. So this is inferior leads, 2, 3, and AVF, and lateral leads. Okay, and again, marked here in blue, we have the lateral leads, and the inferior leads, 2, 3, and AVF. Okay, and again, we're looking at the limb leads. We're not really touching those precordial leads in the horizontal plane. Okay, this is all frontal plane. In the inferior leads, we said we are going to see these QR complexes. Okay, small Q wave and then a large R wave. Okay, in the lateral leads, small R wave and big S wave. So why are those coming about? Okay, so first let's look at these small waves, the small Q and the small R. Well, the small Q and R are going to come from vector 1. Okay, I'll label it 1 for you. So notice that this first vector is heading towards 1 in AVL, so it's upright in those leads, and it will be a negative deflection as it goes away from those leads in 2, 3, and AVF. Now when we look at the second vector, okay, this is this vector here, notice now it's coming towards those inferior leads, okay? So here are inferior leads, and that's why we're going to see the second vector with this positive R wave, okay? Whereas in the lateral leads, as it moves away from it, here's our S wave that we see in the lateral leads, okay, because the deflection is moving away from these leads, okay? Hopefully that makes sense. And then you can see here in leads 1 and AVF, I've put here the RS complex, and then 2, 3, and AVF. We want to see these QR complexes, small Q, big R, again, small Q wave and large R wave. We call that a QR complex. Now these QR complex, we're saying that it requires a small Q wave in leads 3 and AVF. Here's lead 3 and here's lead AVF, okay? Notice that 3 and AVF are here, so they're obviously going to get the most negative deflection compared to the lead 2 that's closer towards that vector 1. Okay, so lead 3 and AVF, we want to see these Q waves present, okay, the small Q waves. Hopefully this is starting to make sense. So the QRS interval is generally normal but maybe slightly prolonged by 10 to 40 milliseconds from this conduction delay. And if you haven't noticed already, these are pretty much the opposite findings in the same leads as we would see in left anterior fascicular block. Now, the true difficulty in diagnosing left posterior fascicular block lies in excluding other causes of right axis deviation. One of the most common causes of right axis deviation is right ventricular hypertrophy, which in turn is a common cause of right atrial enlargement. Therefore, right ventricular hypertrophy and right atrial enlargement should be excluded. Now, other causes of right axis deviation to consider and exclude include acute pulmonary embolism, TCA or tricyclic antidepressant overdose, and lateral MI. So what we here are saying is that there's essentially no criteria that can effectively rule in left posterior fascicular block. Rather, this is a diagnosis of exclusion. Okay, so remember, you have to, and this is one of the main points we'll see here, you need to exclude other causes of right axis deviation. Okay. Now, just a few other points. You may see that the R wave peak time or the intrinsicoid deflection may be increased in lead AVF. Okay, so again, lead AVF, and remember the intrinsicoid deflection. If we have our QRS complex, okay, here's a Q wave and our R wave. Not the best drawing, but anyways, what I'm saying here is that intrinsicoid deflection, okay, of our initial R wave, okay, from the start of our QRS complex to that R wave may be actually prolonged. Okay, so that's what we can see in AVF. All right, so that's the one point here. And also the QRS voltage in the limb leads may also meet the left ventricular hypertrophy voltage criteria. But generally, you're not going to have it associated with the strain pattern, so you're not really going to make that diagnosis. Remember, with left ventricular hypertrophy, we want that voltage and non-voltage criteria met. And just the last few things on the EKG to know, these findings may actually mimic inferior MI or mask a lateral infarction. So you want to be aware of that. Additionally, T-wave inversion in the inferior leads, 2, 3, and AVF may occur, which may mimic post-ischemic T waves. And mark these points because after we discussed infarctions and ischemia, I want you to come back to them and they should make more sense. So this is this area here, okay? So come back to this after you look at ischemia infarction, and I think that will start to make more sense. So clinically speaking, left posterior fascicular block is less common than left anterior fascicular block due to the left posterior fascicle's larger arterial blood supply and dispersed fiber composition. Now, it is rare to see isolated left posterior fascicular block. Rather, it often occurs with the right bundle branch block, okay, aside with it. So again, it needs more damage to actually disrupt this left posterior fascicle because of the dispersed fibers, okay, that we see with it. And because of that, it's often not really damaged, with some sort of minor ischemia. Whereas with the left anterior fascicle, it's even just minor damage can actually affect that left anterior fascicle. So let's quickly go through our notes here before we end. So left posterior fascicular block or left posterior hemiblock is when we have the anatomical or functional dysfunction in the left posterior fascicle. And because of that, the left ventricular depolarization really relies on the left anterior fascicle. Remember, the left posterior fascicle, because it's dispersed, non-organized, and it innervates that inferior posterior left ventricle, it's less susceptible to damage and ischemia, okay? That's an important point to be aware of. Now, in terms of these vectors, remember that first vector is that weak one that's going leftward and superiorly, and because of that, we get those small R and Q waves in those leads. And in vector 2, which is this stronger vector, we have that rightward inferior directed axis or electrical impulse moving in that direction. That's where we get that right axis deviation, the deep S waves in leads 1 and AVL, and the large R waves in those inferior leads, okay? And then if you combine them, you pretty much get this. So you can take a look and go through that on your own. In terms of the EKG criteria, remember, right axis deviation is something that we can see in this, okay? Where remember, right axis deviation here is lead 1. We're going to see a negative in lead 1, as we see here, mostly negative, okay? So we'll be heading this way. And then AVF should be positive, and we do see that with those positive QRS complexes, okay? So we'll be in this region here, which is that right axis quadrant. So you'll see that, but remember, we need to exclude other causes of right axis deviation. Remember, so left posterior fascicular block is pretty much a diagnosis of exclusion. In 1 and AVL, those lateral leads, we'll see those RS complexes as we showed here. And then in the inferior leads, 2, 3, and AVF, we'll see those QR complexes. And remember, we want to see those small Q waves in leads 3 and AVF to make this diagnosis, okay? There's also a number of other features that we mentioned here, and the QRS interval should be normal. It may be slightly prolonged because of this conduction delay, but otherwise it should be fine. Well, that's the end of this lecture. We discussed left posterior fascicular block, including its pathophysiology, EKG features, and clinical significance. I hope you learned something.